The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Hi, George. And we're recording another phenomenal episode today, and part of our innovation series with Dr. Sabrina.
Yes, Dr. Sabrina, why don't you introduce the guest?
I'm so excited about today. Hi, everybody. Today we have Dr. Kim Newell Green. She is the co-founder and chief medical officer at Flourish Labs. So Dr. Newell Green is a pediatrician, a mom, and an innovator with over 20 years of experience as associate clinical professor of pediatrics at UCSF and chief healthcare innovation officer at Kaiser Permanente San Francisco. Her most recent work, she's added entrepreneur to her list of identifiers, becoming co-founder and chief medical officer at Flourish Labs, which is a company that uses technology to scale professional mental health peer support in order to address our mental health crisis. So I'm super excited to have you here today. Welcome.
Thank you so much. I'm really honored to be with all of you today.
So I thought we could start like we normally do, especially when we have our favorite pediatricians on the show. Help us understand a little bit about your professional journey. What made you decide to be a pediatrician? And then how did you come to be co-founding Flourish Labs?
Sure. I can take a step back and talk a little bit about my journey into medicine. And then it'll take a minute to figure out how I got into technology at all, because I'm not one of those doctors who majored in computer science and always was a techie. At heart, I really love the combination of humanities and medicine. And so at university, I studied comparative religions, and people always said, how does that match with medicine? Because I was pre-med as well. And really, traditionally, all the healers in the world have been often very affiliated with the religious traditions. And I love our craft, the art and science of it, as much being a healer as a technician and focusing on prevention and wellness and the whole person alongside the curing of disease, which I think in pediatrics we're all very good at. So then that begs the question of why technology? And really, I'd like to refer to something that Einstein is attributed of having saying, he said, I want to know God's thoughts, the rest are just details. So my brain is one of those that wants to save space to do the big thinking and the complex thinking and use another resource for the details. So I became very adept at using technology as a second brain to help me remember and look up all the things that I always needed to. And because I was pretty adept with using the technology tools in our clinic, I fell into technology leadership roles as I was evolving my career at Kaiser Permanente, where I was a pediatrician here in San Francisco for over a decade. So within those technology roles, and then I lived in Silicon Valley, and my husband is a tech entrepreneur. And so between our social world and his professional world, I ran into a lot of people in the early stages of digital health technology who were starting companies. And my husband would say, oh, my wife's a doctor. You've got to talk to her, and throw these companies at me. And as such, I became curious, and I started doing pilots with some tools that were early and trying them out myself in my clinic, and then spreading them around with all the other practitioners I was working with, and really started to notice that I was having some questions about how do we figure out which of these tools are helpful for the outcomes we care about, that are useful for patients, that might be pretty easy to use by the physicians, the pediatricians, the practitioners in our clinic, and that also can be effective within a healthcare system. So because I was asking those questions, I was always banging at the door of the senior admin team and saying, how do we think about this? And they finally got sick of me, so they made a role for me on the senior admin team as what was called the Chief Healthcare Technology or Innovation Officer, really to ask those questions. When there's a new digital health technology product, how do we think about it and evaluate it? By what criteria do we decide this is a good tool for our patients and for our provider and for our system? And once we've decided at the front line and at the top of the organization that we want to use this tool, how do we get it through the big bureaucratic channels in an organization, lots of siloed people who want to have an eye on the product, make sure it's safe and compliant and all those things. And then once all those people have agreed, how do we actually then get people on the front line to use it so that we can make some impact with patient care, which is what we really care about. So I was thinking about those streams of things. And I was also a very busy clinician. And I really got to a point where I wanted to lean into the world of helping make these products better earlier, because a lot of the things were coming to me and to us, and we would find that they were either not quite right in terms of the outcome they were focused on because they had been started by technologists without a physician in the loop, or they didn't really work well for physicians. They were burdensome. They were adding to our work rather than making our work easier, which is what we must have for physicians. Or maybe they were a great idea, but they actually added cost to the healthcare system. So the healthcare system was never going to use it. So could I meet up with these companies at an earlier stage and really help move technology and the tools we use forward so that they're doing what we need to do? So along that path, I met my co-founder, Obi Felton, when she was at an organization called Google X, which was the big moonshot R&D lab at Google. And they were doing a moonshot in mental health. And she asked me to be an advisor, and I did. And eventually that rolled out into the company, which we now call Flourish Labs. And 2 years ago, she asked me to join her on a big adventure to be an operator and co-founder and chief medical officer of a company doing a tech-enabled service.
Interesting. Yeah, this concept of computers and technology and things, I've seen it over the years where some administrator would think or has a friend that has a company that brings it on in, and they don't even know how to use a computer. And then they try to get Dr. Bravo to use it, and they wonder why he implodes.
That's right.
That's how it used to be.
Exploding right now, Dr. Bravo. But it happened with all of us with the EMR, where we found that the EMR, in many ways, it was built for billing and administrative services and made our days longer. And so we don't want technology in medicine that makes it harder to take care of patients.
What I've noticed with the technologists, the people that write this stuff, they like to make things more complicated than it needs to be. Recently, I've been demoing this AI scribe stuff.
Mm-hmm.
The best one I found was the simplest one, and that's the one that people will use. I've demoed some other ones. Let me tell you, I don't need to read a book to learn how to use a computer and then write progress notes. Why should it be like that?
Yeah, you're absolutely right. I think people in healthcare, part of the reason that people may overcomplicate things is the pursuit of perfection, because we're all afraid of getting it wrong because the stakes are so high. It's not a software that I'm using to book an airplane. It's a software that I'm using to try to improve the quality of lives of an unhealthy person. So I think sometimes people complicate because of that, but I completely agree with you. On the product side, both for anyone who has to use it, simplicity is vitally important or it won't get used.
Isn't one of the issues around the complexity that the technologists don't have a sort of native understanding of what the problem they're trying to solve? Hence, clinician innovators are so important to that process, right?
Absolutely. Absolutely. So I think that clinician innovators and also really talking to the patients themselves. And so as a provider, I feel like I have some understanding of what families and kids need in a technology tool, but we really have to ask them too. So that's why we engaged in a lot of co-design as we were building our product for young people.
And so am I correct in understanding, it sounds to me like you were always a bit of an early adopter?
My Palm Pilot was my best friend. Does anyone remember what that is anymore?
The ice spring. Yeah. It was a competitor.
Oh, yeah. Nice. I was a Palm Pilot.
And so I'm curious, being the early adopter in your own practice and then in the larger organization, what that experience was like trying to bring along the clinicians that were working side by side with you and what you learned about their comfort and willingness and interest to engage with technology.
Yeah, it's a great question, Sabrina. And certainly part of it, and that's why I said, once we've decided that technology is great, there's a big effort going into how we get people to use it. And I found, and I'd love to hear if people disagree, but that physicians and clinicians are quite conservative and often slow to adapt to technology as a group for a lot of good reasons, for all of those reasons about safety. So because we're working so hard and it actually takes there's a lot of cognitive load in changing the way you do something. And our brains are full with just trying to take care of our patients at the rapid pace that we do and make sure that we're delivering safe and effective care. So you're right that many clinicians are slow to use things. And we used a lot of classic change management techniques, but really also co-designed in a way the rollout of these things in the sense that we would talk to clinicians about what their big pain points are and then think together about how and if a particular tool could solve that pain point. So really focusing on the why this might be helpful to them and then to what they care about the most, which again is the outcome of the patients and families and their experience of care.
Right. I think you hit it all the points that are a problem for implementing new solutions in the exam room.
Yeah.
One is lack of time. If you were to follow the recommendations for all the screening, family practice, internal medicine, pediatrician would spend 23 hours a day seeing their patient. There's no time.
Yeah.
Number two, we have a payment problem. We don't have the resources to add things into our workflow because there's just not enough money. Number three, there's a lack of knowledge. For someone, say for a pediatric neurologist, absent seizures are extremely common. From a pediatrician perspective, I can't remember seeing a kid with an absent seizure. And if mom says kid has a seizure, I go out, tell the care coordinator, set him up with a neurology consult. If he does, I don't know how to treat it. And I don't know how to rule it out. I don't read EEGs. What else am I going to do?
Yeah.
So there's a lack of knowledge because we can't be knowledgeable about every subspecialty. The same thing happens in type 1 diabetes. People don't know how to diagnose it. They don't know how to screen for it. And it's not top of their mind. And then there's anxiety. We don't want to do wrong. So since I don't really know all a lot, I get imposter syndrome. But I'm going to use an app to diagnose your depression, tell you it's going to get better. I'm not a ped psychiatrist. Maybe this company is just telling me lies and I'm being their sales force and I'm going to do harm to this kid.
Yeah.
And finally, it is extremely difficult to have difficult conversations with patients. And difficult conversations are not just end of life care or your child is dead or your child has cancer. Even just telling a parent, I think your child has depression. And I'm not sure because I'm not a pediatric psychiatrist, but it looks very much like depression. And I want you to use this app. And I'd like to see a pediatric psychiatrist to confirm your diagnosis. That's going to take a year. So I'm the best you got. And I got to smile and make you believe that I am the top of the food chain on adolescent depression when I know I didn't do a 5-year fellowship residency in psychiatry.
Yeah.
And so I think those are always there. And I used to think that pediatricians were just difficult and intransigent. But the more I studied the barriers, these are real tough barriers to overcome.
I was just going to say that to that point, there's so many points I could unpack. I'm sure you all could in that very exhaustive list of all the challenges. But one of the things that I always say is that I'm a pediatrician by training, but a mental health expert by the seat of my pants because so much mental health comes into primary care these days.
Yeah.
And access to other providers is terrible, as we all know. And we have to become relative experts. We have to engage in this to figure out how can we, rather than just referring, do some tiny little bit of, give some help in that moment, because that's when the patient is there. And also, it was why I was so compelled by this idea of working on the problem of workforce and mental health. So how do we grow the workforce rapidly? Because we know there isn't a big enough workforce. And how do we expand our concept of who the team should be could be in mental health to really explore people who have the time and space and expertise to help us manage our patients as part of that team of care.
So that is a perfect segue. Thank you so much. So maybe you can help us understand where peer coaching fits into our existing approach to mental health services and how you see potentially the solution addressing some of the urgent needs that we have.
Yeah, that's right. So let me talk a little bit about the word peers. We all know about peer counseling that we had in high school and college, often a free service where there isn't really any training. There's a lot of coaching in medicine these days, and there are a big variety of training programs. You don't exactly know what that means if you're sending someone to a coach. What we do is something that's actually quite specific, which is we train folks from 18 to 35 to be certified professional. We call them professional because they're paid for their work and they're certified peer supporters. And peer support in this context is folks with lived experiences of mental health issues who are trained. And the training is recognized at a state certification level in their national standards. So we have an 80-hour training program. It's actually recognized and accredited in the state of California as an official Medicaid trainer for certified peer support specialists. And so it really is a workforce that is part of the landscape of mental health. So peer support in an informal and volunteer way, many of us know because that's what AA, Alcoholics Anonymous, NA, those kinds of services are. But there's actually been decades of research that suggests that people with lived experience who engage in a strength-based model, who say, look, I've been in your shoes and I'm here to show you that there is a path to recovery. And let's look at you and your strengths because you have everything you need in you to recover. And let's together set some goals and follow you on those goals. So it's a non-clinical strength-based support system. And there's decades now, several decades of good evidence that it's effective in mental health support. It's effective in decreasing symptoms. One of the things that peer support is most effective in is engagement. So many people with mental health struggles also struggle to engage in the support system, go see their therapist, take their medicines, et cetera. And peer support really helps with engagement. It also has been shown to decrease cost of care many times, decrease hospital admissions, ED admissions, those kinds of things. So we really believe it's a really wonderful way to augment care. And the fact that we can train this workforce so much more rapidly than the 6 years it takes to become a licensed behavioral health clinician.
And so where does it fit into our current pathway? So we see a kid who is either in extremis or we anticipate that they need some sort of mental health services, whether it be meds or therapy. How would we be thinking about using peer coaching?
So this is an interesting thing because peer support is very evidence-based and it's very nascent as a field. It exists often in kind of siloed areas, small nonprofits train these folks, and it's more often used in substance use now than it is broadly across. So many folks, particularly pediatricians, and I didn't really know about what this was like. I had experience with community health workers and some international work, global health work, where I saw that small amounts of training of a person who's from within a community can really massively be a force multiplier in the health of a community. So I buy it as an approach, but most pediatricians don't know about this. So I'll first start by saying peer support has been shown to be effective across the acuity of mental health concerns. So peer support is a great place to send folks who maybe are on that verge. We're doing preventative care. They're what some people call subclinical care, but I believe it's vital and important moment where someone has some big trauma. They're stressed about admission to college. They've had a breakup. They've got some traumatic things going on at home. That's a great place where peer support before someone develops a clinical diagnosis can be really effective at preventing that. As we move up the spectrum, peer support is effective often for mild conditions like anxiety and depression, maybe even alone. But as you go along the spectrum, peer support's been shown to be an incredibly important augment to care on serious mental illness, whether that's bipolar or schizophrenia and psychosis. Folks who have peer support are more effective in their long-term care, again, have reduced hospitalizations and higher levels of acuity. So you can think about it along the whole spectrum. And then the question is, okay, how do I know about it and how do I refer people? So I can talk a little bit about there are many organizations who provide peer support. I can talk about how our platform works. So our platform, what we do is...
I have a question. When you say shared lived experience,
right.
What does that mean?
Great question. So I think that's a great question. We asked ourselves that too. And in fact, in our co-design sessions with young people, when we were saying, okay, what might it look like to bring peer support as a mental health adjunct to young people? What do they want in mental health providers? One thing they said, all the mental health support I've ever gotten is from, no offense, doctor, but someone who looks like you. They're old, they're white, they're cisgender, and they don't get me, right? And I want to share my stuff with someone who gets me. And so we thought about peer support as the lived experience of a mental health condition you can match with someone who has OCD, who has experienced anxiety, who has depression, maybe has survived suicide attempts, if those are issues for you. And on our platform, you can also match with folks whose life experience is shared. In other words, I want to talk to someone who's Black and has experienced racism like I have. Or I'm LGBTQ plus and I feel like nobody gets that and what that's. And so our platform allows you to match both from those broad range of life experiences as well as specific shared mental health things. And we believe that some people need a village of support. Like I have friends who I talk to about my kids' troubles and other friends who I talk to about relationships with my parents or my spouse. And so people may want several peer supporters to connect with around particular issues they're having.
So I understand some of the basic concept.
Yeah.
Let's say if you're newly diagnosed, I'm talking about the parent of a child with sickle cell disease, or you're a newly diagnosed parent of type 1 diabetic.
Yes.
Or you are a newly diagnosed parent of a child with dislocated hip, congenital dislocated hip.
Yep.
And obviously that's going to cause a lot of anxiety.
That's right.
So when I try to match them with a peer support group, am I looking for someone that, forget about the race, the gender, the ethnicity, am I looking for someone who has experienced sickle cell disease in their life and anxiety at the time of diagnosis, or I'm just looking for someone that experienced anxiety when they were giving a diagnosis with an uncertain future?
Yeah, it's a great question. And I think the answer is it depends, but let me pull out two pieces of what you're talking about. So what we do at our platform on which we deliver peer support is we deliver virtual peer support to youth. So 13 and above, 13 to 30, because we do youth and young adults. And we broadened it to 30 because we were talking to a lot of students, university and college students, and they said, what the grad students said, we want this too. So we deliver care to what we define as adolescents and relatively young adults. There is a big movement in peer support, often official certification for family caregiver support. And so that's a little bit more what you're talking about on the parent side. So there's official peer support for family members. Now, the other piece that you're talking about is the bulk of peer support focuses on mental health conditions. But we know that peer support, and there's some studies that suggest that peer support is often very effective in physical health conditions as well. So for a patient themselves, peer support can help them manage their care better and have good outcomes, whether that's or new diagnosis of diabetes in an adolescent, cardiovascular disease, et cetera. And then we also know that caregivers often need a support network. So I think that whether that has to be a support network of someone who's had anxiety about the diagnosis in their child of any disease, or that more specificity of I'm just like you because my kid has sickle cell disease, I think that'll depend. The theory of peer support is that at some level, I get you. I've had some of the shared experiences. We're never going to have the perfectly same experience. So the idea is I see what you're going through. I've experienced some of it, but I'm going to learn from you what it's like for you. And then we'll talk about steps to make this better for you.
So are we providing medical care using unlicensed medical people that happen to have experience in that disease process or disorder?
We're not. That's a great question. So peer support is not clinical care. So what they do is they don't talk about treatment. They don't talk about medications. They don't talk about diagnoses. It's a support mechanism. So it's non-clinical certified people. So think of it as the health educator in your office, or if you're lucky enough to have that. I was very lucky to practice in Kaiser Permanente, where we had a whole team of people around us who helped augment our care. We had lactation consultants. We had health educators. We often had other folks. And we had some behavioral health techs who weren't fully licensed as a social worker or a therapist, but they had experience in training in behavioral health. So that's how I'd think about this type of augmented care.
I think part of the difficulty is that unless you practice in a Kaiser, more of this holistic environment, it's a really foreign concept.
Yeah, that's right.
But I would point to there's a lot of good quality research around parent mentors. And to your point about peer support, they've looked specifically at asthma and I think around Medicaid redetermination, and incredibly effective to have someone who has some similarities with your background to hold your hand as you're walking through your experience. It's just not something clinically that we've been able to access, I think. So it's hard for me to get my head around, how would I use this?
And I think even though, to your points, Herb, about how hard it is to get pediatricians to use a technology, this isn't actually hard technology. This is something where It's a website. You say to your parent, you describe what this is. You say, go to peers.net, and then it's really in their hands. There's a matching platform on which they can choose the peer supporter that they want to see. They can immediately book an appointment within 24 hours. So it's a very easy user process, as we've been talking about. That's what our goal was. And so the pediatrician doesn't have to be facile with technology. They can just need to remember or have on a piece of paper, peers.net. However, it's like going into our practice and changing it and getting our brains around this totally new type of provider, figuring out, can we trust this? And so one of my jobs is to make sure that our care is safe and effective, and then I can talk about how and why. So we do a lot of work. Within Kaiser Permanente, we care a lot about quality and have all kinds of measurements. So we do measurement care. We do a lot of work to look at our outcomes. We do a lot of patient-related outcomes. We follow our access. So I can provide lots of background to folks who are interested about how we do supervision, how we do crisis and escalation work, what is the quality, what does our care do?
Sabrina, what's my favorite question?
Well, I love your favorite question. The favorite question is, who's paying for this?
That's a great question, George. And it's the real bugaboo for us too. So we came into this business with this recognition that peer support has been paid for by Medicaid. There's a code for it. In the year 2007 is when that code came out. So Medicaid plans, many of them actually have peer support as a part of the behavioral health services that they do. And commercial plans are getting on the wagon too. And so many commercial plans pay for this as well. Now, what we found when we dug deeper is a variety of challenges. And we all know this. Healthcare is so ridiculously complicated in our country. And so all we can do is pick away piece by piece. We have leaned into Medicaid health plans, but as you all probably know, every Medicaid health plan they say if one Medicaid plan, because it's administered differently. They have different certifications and regulations. And then you have to not only understand the Medicaid regulations, but then there are the managed care plans, and you have to talk to them, each of them individually. So right now we're working very hard and getting some really good traction with Medicaid to health plans. We leaned into those because that's the most vulnerable population, and we deliver pretty high cost and low value care. And so we are now covered by a Medicaid health plan.
High value, low cost.
Did I not say that? That's what I meant.
That's the opposite. And I know you're not delivering that.
Thank you very much, Sabrina, for clearing that up. So we've got a Medicaid plan. We're delivering. We just started a contract today with a really cool program in Nevada called Connect Nevada, by which they're trying to reach out to kids who are at risk of out-of-home placement. And we're part of the support team that's helping to make sure that doesn't happen and support these very vulnerable youth. And we're very close with several commercial insurers as well. So the goal is that this would be covered for every kid by everyone. In the meantime, we have on our website a price that you could pay to get this. It's half of the price of what insurers reimburse for regular therapy or sort of routine therapy. It's a quarter of the price of what I pay for my own daughter's therapy in San Francisco with a private therapist. So again, relatively high value and relatively low cost, but we don't want people to have to pay for this. So what we do in the meantime is we've come up with some very complicated and hopefully innovative ways to get some free care for folks or lower cost care. So we have philanthropic funds that we use to deliver care to partners. So we partnered with Trevor Project, for example, which is a major national organization that supports LGBTQ plus folks in crisis. They have a crisis line. And what they find is that they have frequent flyers. They have folks who come back and back. So they're clearly not in need of one crisis support. And Trevor Project's goal is not longitudinal care. So we have a relationship by which they are going to feed us some of those folks who need another level of care. And we have a philanthropic organization who has very generously donated to Trevor Project specifically to pay for free peer support for the folks they refer to us. So we're doing all kinds of complicated financing to try to get this to us. We also have on our website, we have a financial aid form so that people can apply for financial aid and get reduced cost visits. So we're doing our best to get it covered.
It sounds like this is like a community health worker.
It is very much like a community health worker. You're absolutely right.
Yeah, that's what they're pushing in New York, community health worker, somebody that's unlicensed, that provides some kind of referral, connections, therapy, filling out forms or surveys that do not require the the expertise of a physician or a nurse or a licensed professional.
That's right.
But it has to be billed out under the physician's NPI number, not the person.
Yeah. So the billing
It's a problem.
is complicated. It's
True for peer support too.
I don't know, probably.
Yeah, it depends on the state. So many states right now are having these traditional or community health worker programs. In California, we have community health worker program. We have things called a mental health coach that is now being accredited, and they are still figuring out what that means and how to reimburse for it. And there's peer support specialists. We are doing peer support. And what we think makes that unique is that, one, there's loads of evidence about it. It's an evidence-based support system. And we really believe that this notion of the shared lived experience, not only around maybe cultural values which community health workers have, but also around the mental health condition, is a vital part of its secret sauce. In terms of the reimbursement, there are states in which the peer support has to be reimbursed or billed under a licensed person's license. And we have medical directors in the states we're working in. I often am that person, but we have other licensed behavioral health clinicians who they bill under. So it would not be ever under the pediatrician, for example, that referred folks to us.
What are the ways that I think about peer support as an intervention? And I'm curious how all of you would respond to this. But I think about it in this category of low intensity interventions, which I didn't really know what that term meant until recently. But in my practice, over 13 years, you'd have these kids come in who were in extremis. They needed care immediately. They were really not doing well from a mental health perspective. And this was pre-COVID. We weren't doing virtual care at all. So access to mental health services was almost zero. We all remember that. And one of the ways that I would temporize things for them, and this was also before I had REACH training to be able to prescribe meds appropriately, but one of the ways that I would temporize them was say, okay, I know that their sleep is disrupted. I know that their eating habits are contributing. I know that there are certain behaviors that are contributing to their crisis. So what can I do about that? Let me see you every week. That's something I can do. As long as I can squeeze you into my schedule and insurance will pay for it, I'll see you every week and we'll work on, we would do basically using the elements of motivational interviewing to focus on one thing at a time until they get off the wait list and can see a mental health professional. And then maybe at the same time, we do both in parallel. And so I come to realize that there's a body of literature around an intervention like this, low intensity interventions. And I think about peer support as a similar intervention where it may be not necessary for the clinical provider to be providing that level of support. And they may not even be ideally suited. Like how I'm not trained to provide counseling necessarily around behavioral modification, although it's something that I learned in my practice. And so I put that in the same bucket of things that we can do that might in some cases, and I'm not aware of literature on this specifically, but might in some cases actually reduce the number of kids who end up with diagnoses and need a higher level of care. I don't know if that's something that's been discussed around this sort of an intervention.
Yeah, that's right. There's so many thoughts following that, Sabrina. One is you too became a mental health provider by the seat of your pants. And the structure of our pediatric visits is that they're very short. And so some short interventions can actually be super effective in mental health. But often it's just those things that unpacking what's going on needs more time. So that's where it's harder for a pediatrician to do that. A provider like ours who can spend an hour, 50 minutes, an hour with a patient just can do more work that you can't do. But that it's really important, those low intensity interventions. And I just heard a wonderful webinar, and I can't remember the details of it. It was some folks out of Boston and LA who are doing interventions in the emergency department around with youth who are having acute mental health problems. And I can send you the link to put in the show notes later because it's a wonderful webinar. But effectively, what they said was that in an emergency department, when a youth comes in with a mental health crisis or a significant issue, what the psychiatrist does or the licensed clinician does when they come in is basically diagnose and triage. They figure out their disposition, diagnosis and disposition, but there's no treatment in that moment. And what a terrible thing to lose is that moment where you could begin the kind of care that will hopefully de-escalate it so that maybe they don't need hospitalization or some of the really more onerous and complicated things. And so they piloted an approach where social workers in the emergency room immediately start to deliver evidence-based psych care that's a low intensity, short intervention. So yeah, I completely believe in that sort of thing. And I think that peer support absolutely has a role in thinking of it about it in that way.
Yeah. And moreover, when it's that instead of being the social worker, it's someone who looks like you or someone who's been through that and can immediately hold your hand and say, I've been through this. I can't give you the solution, but I'll hold your hand while we go through this journey. I think to me, just instinctively, it has such value.
It does. And George, to your point about what CHWs, the community health workers do, the peer supporters deliver both a lot of listening, a lot of strength-based and goals-based, drawing out those kinds of things. But they often do things like help people navigate the care system as well. And peer support on the ground is often that, like, they'll take kids who have been in crisis or just discharged, and they'll take them to get a new outfit or get groceries or help them get a job or fill in a form. And so that kind of life management stuff is also within the purview of peer support.
Yeah.
How long do you keep someone in the program?
That's a great question, too. So we find, Herb, that there seem to be, and we'll learn more as we grow and do more care, but several buckets of people in our program. We have folks who do, and there's a growing movement actually in the psychotherapy world that talks about single session therapy, although someone I just talked to calls it now one at a time therapy. So you might have a big issue and you come in and you just need to talk to someone for an hour, figure it out, and then you move on. And there's more and more studies talking about how that's effective. So we do find a bunch of people who come in, what they say after the visit, they give great feedback and they had a wonderful time and they just come once. The bulk of our folks do 4 to 6 sessions and they have someone hold their hand as they try to progress towards some goals, which are probably pretty difficult for them. And then we have one person who has been on our platform for more than 15 months, who's someone with a serious mental illness who has a care team, but is stable and actually finds peer support to be the maintenance therapy. That's all they're doing right now. And then the peer supporter helps them notice when they're sliding or things are getting tough and sends them back to their care team to get them under control again. And then they come back and do it as maintenance therapy. So it's an interesting and, again, high value approach to that side of things.
So where does technology come into play here? This is such a human service, and that seems to be part of, like, the majority of what you're providing here is a human interaction. So where does technology come?
Yeah, great question. So we use it in 2 ways. First of all, we're fully virtual. So what we can do, it's a tech-enabled service in the sense that this is on an online HIPAA-compliant platform. When we ask young people what they want, care now, and they want it to be on their mobile device. They don't want to have to schlep across town and go to someone's office when they're trying to get their lives done, which is true of many of us too. And so that's the first step where technology helps. And it helps facilitate the matching process and setting appointments and just makes that easy for young people who grew up in a world where everything they do is pretty easy and tech-enabled. So that's one piece. The other piece that we're really diving into right now is how we use AI to do this. And we think of AI as something that will augment our care, and we'll use it largely for 2 functions. One is to help us with quality and risk management. So we have an AI tool that is provided by an outside organization that is really steeped in using AI to help support high quality behavioral health that will record all of our visits and then can do things like screen them for missed risk flags. So did the person seeking care say something that the peer supporter missed? And then we can go back and we can say, oops, let's make sure that we take care of this thing that might be developing towards a crisis. We can do quality management, and they have a really good way of helping manage the actual way that people deliver care. So are they doing motivational interviewing in the right way? Are they using empathy at the right time or active listening? Or are they talking too much? So that we can use it as an augment to the real human support that that our peer supporters use. And then it can help them do the note too. So that piece is just out of the equation as a way for them to spend the time they can focus on the person they're supporting. So that's one way. The other thing is that we find that youth often don't want to just immediately sign up for a video connection, even though we believe video is vital because it is human. We want them to be in real conversation with real people that they can see, even if they're not in the same room as those people. Because we believe that loneliness, really comes from that lack of communication with real humans. And that's a big part of mental health. But often young people are dipping their toe into the water of this new experience, and they want to do so in more anonymous ways where they don't have to put themselves out there. And so they're really engaging in chat, real-time chat a lot. And right now our peer supporters support that, but there are some good examples of where AI can just ease us into the chat, get some of the easy, simple questions answered that will get people towards that level of comfort so they can really make the real connection without relying on AI to do the therapy itself.
What's the responsibility of are there regulatory constraints, or is there some responsibility that you think about the peer supporter, peer coach having when they're engaged in a conversation? You mentioned using AI as the risk stop. What is your responsibility there, ethical or from a regulatory perspective?
First, ethically, which is what we ultimately care about. As I said before, we want our company and our peers to deliver safe and effective care. And that's a big part of the training, is how to do that, is to for them to know how to stay in their lane, to be within their scope of care, when to get help, when you're uncomfortable or feel nervous about an interaction or someone saying something that you don't like. We have immediate access to supervisors at all time. We have one-on-one meetings and office hours and all kinds of ways that they can get support in what they're doing. They really have a sense. There are written ethical principles for what peer support is that are nationally written. SAMHSA has ethical guidelines on this. So there's a big body within peer support about what are the ethics of what we do, how do we do it safely. On the regulatory side, peer support is new-ish in some ways, but every state has regulatory things about how peers are certified and trained. They have to get CEUs, they have to be retrained. So there's a lot of stuff around the training. And we created our own training that meets, again, state and national guidelines. And then we decided that because we want the whole world to know that this is safe and effective care, and we want to collaborate well with the healthcare system, that we wanted to set up our company as a healthcare company, which you don't really have to do with peer support because it's not officially clinical, as we discussed before, but we set up the legal structures at great time and cost that we run like a healthcare company. So we have this complex legal structure, which is we have something called a professional corporation that holds all the peer support because businesses can't do the practice of medicine. So those functions are completely separated. And we are fully HIPAA compliant. We have all of the policies and procedures that make us really acceptable to the healthcare environment.
That's such an interesting point. I wonder to what extent companies that are providing healthcare adjacent services are holding themselves to healthcare standards, both for data privacy and security, and even just the technological security elements that would need to be in place.
That's right. We know companies that are not, and they're doing it for a variety of reasons, and it's less expensive and it makes it easier to scale and succeed. But we just wanted to hold ourselves to that standard.
Is there a checklist that providers can use to better understand? So in your case, how can a provider who wants to access your services for their patient, how can they understand whether you do hold yourselves to those standards? Is there some way to assess that?
Yeah, I don't know about a checklist. There are all kinds of things that one has to do to be HIPAA compliant and think about safety and security. We try to be as open and educational on our website for people like individual practitioners, community clinics, other organizations that support youth that we're partnering with. And we have all kinds of information about exactly how we train and to what standards, exactly how we supervise, what are our quality metrics, those kinds of things. And on the quality side, I'll mention that we care a lot about both building evidence and having an outside source look to see, are we safe and effective, as well as building the evidence about peer support in general and its efficacy, because that's a literature that can continue to grow. And so right now, there are investigators at Berkeley and Santa Clara University who are doing a randomized control trial. We'll have early results in the fall, looking at the clinical effectiveness of what we do with mild to moderate to severe anxiety and depression. And then we've got 3 or 4 other investigators who are proposing studies as well. So once we have those results, of course, we'll publish them. But we do have internal quality scores based on patient-reported outcomes and then access engagement scores. And we're very proud of what people think their experience of care is.
I know in the U.S., anyone can sue you for any time. just the way the law is.
Say that again. I'm sorry, couldn't hear her.
In the U.S., anyone can sue you for anything at any time.
That's right. Yeah. So just be clear, it's scary, right? It's to some extent, I'm the medical director of this organization, and it is my professional license. We have, of course, all of the proper insurances and things, but it's my license and reputation on the line. And again, that's why I get all of the advice I can from everybody who understands how to do healthcare well and safely. But it's still, anything could happen and anyone could sue us at any time.
And so I would be a little concerned sending a depressed teenager to someone that doesn't hold a license.
Yeah.
And then for whatever reason, that's a one bad apple, because there's always going to be one bad apple everywhere, anywhere. And I get embroiled in a lawsuit, which can happen. I can send to a really good psychiatrist and they mess it up and I get embroiled in a lawsuit because they're going to name everybody in that chart.
Yeah.
But at least I can mount a defense of, I sent them to a residency trained, fellowship trained pediatric psychiatrist with 15 years of experience. How much more due diligence can one do? That's all I can do.
Yeah, I think that's right. I think the other side of that coin is to look at what's happening today. So the statistics are that something like 45% of young people these days have a diagnosis of some kind of mental health issue, and more than 55% of them get no care at all. So forget about get sued. My heart is going to the mission of how do we get support for these young people who are deeply in crisis right now? And so I feel comfortable enough with the evidence base of what peer support is that I feel like this is a viable and important means of trying to get people the support they need. And I recognize that many people, particularly in medicine, as we started this out with the conversation of how conservative we all are and how the way that healthcare is delivered in our country with such legal difficulties makes it very hard to sign up for something that's new or doesn't feel like we were taught it in medical school, or it's maybe not standard of care yet. But I'm going to push that because I care about these youth.
And to be clear, are you suggesting that it's used in place of standard of care or used to augment standard of care?
Absolutely not. It's absolutely an augment for the care we already deliver. And often it's during that waiting period where it took my daughter 3 months to get into care. And we really needed care yesterday, not in 3 months. When youth are discharged from the emergency department, they often are discharged to nothing to avoid. When youth are discharged from an eating disorder into IOP and PHP and these intensive programs, they're often discharged into a void and they have to go back into home and school where all of their eating behaviors and habits were so difficult with no support. And having a friend alongside them, an educated friend, a peer, can be incredibly helpful.
Yeah. Yeah. To me, it feels the challenge is for providers is for us to be able to meet the standard of care with the resources that we have, which it's already hard, right? If our average visit is 12 minutes, then we're supposed to do screening and refer to the right professionals. But we still have to do that. This is just another tool in that toolbox. And at least my experience on the ground has been that I just need more tools. I need more tools.
And these are tools that I believe are actually standard of care, evidence-based. I can also send you for the show notes some documentation from Mental Health America, from SAMHSA, from major organizations in the mental health space who suggest that peer support should be a part of all comprehensive mental health care. And in fact, there's a big model for CCBHCs, which are Certified Community Behavioral Health Centers, which is a model that's being rolled out in many states initially as a pilot from SAMHSA, and then more broadly now by CMS. And CCBHCs are required to have peer support in the loop for all patients who use this comprehensive care model to manage their mental health issues. We may not know about it in pediatrics yet, but we should, and we're going to.
I think since you're using unlicensed professionals, medical professionals, people with experience in some particular condition, there's some kind of a protocol, doctor curriculum, doctor pathway, algorithm, whatever you want to call it, that's created by somebody, or they just go off the hip?
There's certification standards. So the 80-hour training that they go through certifies them. So again, they're unlicensed, but they're certified and trained. And in our company, we have specific templates that are used for every single visit that include things like at the beginning of the visit, they orient them to what's going to happen. They review mandatory reporting requirements, just as we would in a visit with any teen who wants to talk to us about sensitive issues. They talk about and ask about suicidality. And if a youth admits to suicidal feelings, then they go through the Columbia screening, and then they have protocols by which they immediately send them for extra support. They get a supervisor involved. And in our case, we manage crises by referring to an outside organization. So we don't provide crisis care, but we will accept youth who say that they are having suicidal thoughts. And the bulk of the time, they're not actively suicidal, and they can have their feelings de-escalated. And with close follow-up, we can manage them at home, which is so much better than them going into the system most of the time, where they sit in the ER for 12 or 24 hours as a suicidal youth, but in front of gunshot wounds and heart attacks, and are pushed to the side while they wait for that kind of care that they get. But in any case, when someone is actively suicidal or in any kind of crisis, we have an organization called Protocol that does crisis support with physicians and licensed folks in the loop. And we do a warm handoff on the video directly to those folks. So we have lots of processes and procedures in place that help support these newly trained but fully certified individuals in delivering care.
I agree that most youth are not actively suicidal.
Yeah.
Okay. But it's like Russian roulette. They're not actively suicidal until they are. And even me, a seasoned physician, has sometimes difficulty pointing out you're active and you're not.
Yeah. I will say that suicide is something that is very scary to me and to our whole team. Absolutely right. And we know that there's suicide, there's too much suicide. And so all of us are deeply involved in continuing to educate ourselves more and more about what's the evidence base of what is actually impactful in suicidal use. How do we manage that? And I didn't know enough about that as a pediatrician. I knew much less then than I do now. And then our whole team of peer supporters do, to be honest. So it's very seriously. Go ahead. Yeah. Sorry.
I think that's becoming a bigger problem, because what I've noticed before COVID, I brought in the Reach Institute to train our group of pediatricians on how to do more in terms of mental health. It basically was, how do we effectively prescribe and manage meds for sort of entry-level conditions. And so what I'm finding since then is that more and more primary care pediatricians are doing this. Right? We're developing more comfort. And I think that's the institutional message is we should be doing more of it, because there aren't enough providers to handle, not enough psychiatrists to handle the load. So we need to be doing more of it. And so it really becomes a problem for us, because not only are we managing the meds, these are kids who have diagnoses, but we have to also be convincing ourselves that they're safe to be out in the world and don't need to be, and that we're not worried about them being actively suicidal. And to me, that feels like the same problem that we've always had to deal with. It's just exacerbated and has less to do with these kind of ancillary tools that we can add to our toolbox. I'll just say that in my FQHC, what I notice is that because pediatricians are more and more taking on this responsibility, the attitude is that we have addressed the mental health crisis. But what is happening is that kids are getting the meds and they're not getting the therapy that we know from the evidence needs to go along with the meds. And I'm curious from your perspective, Kim, having worked with Medicaid plans, whether there are levers from the outside that they are beholden to, maybe metrics, quality standards around meeting mental health care needs, that tools like peer support, virtual therapy can pull in order to say, look, you really need to include our services in your menu because you're currently not meeting the demand. Because my experience has been that on writ large, they're not meeting the demand.
For sure. Yes, absolutely. I think we have been in conversation with some of the administrators, or one administrator in particular at CMS. So at the national level, CMS has written guidelines about how all of the Medicaid organizations that they're funding and reimbursing should be delivering mental health care for youth in particular. And those regulations include the recommendation that they provide peer support as a part of this comprehensive care. They also provide lots of recommendations, and I'm not an expert in these, but about things like care delivery in the medical home that has some very close attachment to behavioral health. So those are models that people are really integrating more. But it's slow to evolve. And so CMS can say to states, we want you to do these things, or they can say you must do these things. And I think in recent conversations, what we're hoping they will do next is do more of the you must do these things, and then they'll regulate that and hold states accountable, not only for peer support. And just to be clear, I'm part of this company, but ultimately what I care about is getting youth all the care and support they need, whether that's my own children and family, the community that I sit in right here in Northern California, and or the whole community of youth in America who are really suffering right now. So we are advocating for stronger and more effective and more integrated approaches to behavioral health. And it's just chipping away at that problem one step at a time and not get too cynical about the speed of change that happens in a large bureaucratic organization like the United States of America.
Amen to that. So I see that we're bumping up against the end of our time. Maybe I'll just throw you one last question do you have a minute for that? So what I'd love to understand, in my circles, at the table where there are innovators, there seem to be a disproportionate number of pediatricians. And I have yet to really understand what that's about, but I love it. And so I'm curious, from your perspective as a pediatric innovator, what are the biggest challenges that we're facing innovating for our population?
Pediatric innovators, holy moly, you're absolutely right. I know so many pediatricians who are working hard to make things better for children and families. And they do that at every level. Like every one of our pediatricians sitting in their office all day long, that's what they do. And it's hard work. But I think that the real challenge, I always say that the pediatric budget is the period at the end of the sentence that's describing healthcare in America or in any organization, in an insurance plan. And so the money is not that the cost incentives don't exist to change things in pediatrics in the same way they do for adult medicine, particularly in primary care. And for the money is in complex care, complex patients, older patients, et cetera. So that said, again, it's so important that we all continue to preach the message that it's these very early life experiences that lead to a lifetime of cost in the system. And Medicaid is a place that owns that person's life in many cases for their whole entire life. So Medicaid is incented to do this early life preventive care from the perinatal stage, which is another area we're really passionate about. And maybe most pediatricians know this. I didn't know this number, but 75% of mental illness presents before the age of 25. And there is evidence that if we catch it early and treat it appropriately, we can prevent the lifelong consequences that lead not only to so much distress for human individuals and their families and caregivers and their whole community, but also lead to lack of productivity, increased costs in our economy. So that's why I'm just so passionate that I'm beating the drum, as so many of us are, that we have to pay attention to the kids and we have to pay attention to mental health in pediatrics.
Thank you. Wonderful. So having you, Kim, this was such a great conversation. Thank you.
It was my pleasure. And thank you for all the work that you do and in putting forth all the important pediatric messages. I love your podcast.
All right. Thank you.
Have a great day.
See you soon. Bye.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.